Okay, so this is Chapter 31, Nursing Care of Patients with Lower Respiratory Tract Disorders. For ATI, this is Chapters 19 through 24 in your Med-Surg book. This starts on page 6. We're going to talk about disorders of the lower respiratory tract, signs and symptoms of each of these disorders, diagnostic tests, therapeutic interventions, and of course, like always, nursing considerations. So bronchiectasis is caused by a dilation of the airways, which causes them to become flabby, which allows secretions to pool. These secretions are really difficult to cough up, which leads to these recurring infections. These usually occur secondary to other chronic respiratory disorders such as cystic fibrosis, asthma, tuberculosis, bronchitis, or exposure to toxins. Signs and symptoms include dyspnea, cough, large amounts of sputum, up to 200 milliliters with a single coughing episode, anorexia, recurrent infections, clubbing of the fingers from chronic hypoxia, and then crackles and wheezes. For diagnosis, the X-ray, they don't really show anything early on in the disease. A CT scan can provide a better view of the dilated airways. Sputum cultures to determine the infecting organisms, and then other tests to find underlying causes, like they may do TB testing or other types of testing for cystic fibrosis and the like. So they'll do some secondary things to try to find out if there's any or what is the underlying cause. So for therapeutic interventions, the goals of treatment are to keep the airways clear, control infection, and then to correct any of the underlying problems. So you'll see things like antibiotics, also vaccinations like flu and pneumonia. Expectorants can be used to help loosen and mobilize secretions. Bronchial dilators improve airway obstruction. The chest physiotherapy to help mobilize secretions. Certainly they can use supplemental oxygen. There can be surgical resection to remove diseased areas of the lung if the cases are severe enough. Then they can also do a lung transplant, or a lung transplant may be considered. So pneumonia can be certainly acute lung infection, or it can be inflammation and alveolar damage, where the alveoli fill with exudate, and this reduces the surface area for gas exchange. Some bacteria that can cause these infections can also cause necrosis of the tissue. So etiology usually is bacterial. Usually it's a Streptococcus pneumoniae. There can be viruses as well. If the person does have a viral type of pneumonia, this will increase the risk for susceptibility to a secondary bacterial pneumonia as well. It can be a fungus like Candida or Aspergillus, which are the most common. It could also be from aspiration. Aspiration pneumonias also increase the risk for susceptibility for bacterial or secondary bacterial pneumonia as well. They can be from artificial ventilation or ventilator-acquired pneumonia, or VAP. Here, because the ET tube keeps the glottis open, allowing secretions to get into the lungs. Hypostasis from hypoventilation, people that are on bed rest or immobile or are taking shallow respirations, or it can be related due to inhalation of chemical toxins. Again, here there's an increased risk for susceptibility for a secondary bacterial infection as well. So high-risk patients include the very young, elderly, people that are older than 65, hospitalized and intubated patients, and anyone who's immune compromised. So prevention, you can get a flu vaccine. Also, there's pneumonia vaccines out there. Certainly encouraging coughing, deep breathing, and position changes for folks that are on bed rest or are more immobile. Hand washing for sure, which prevents, spread of infection or spread of any infection. And for folks that are on ventilators doing frequent mouth care, they also have continuous suction setups for ventilated patients as well, keeping their head of the bed 35-40 degrees, and then also doing sedation holidays. Remember, I've mentioned before that they do have VAP protocols in hospitals as well. So signs and symptoms include chest pain, fever, chills, cough, dyspnea, a yellow, rusty, or blood-tinged type of sputum, crackles and wheezes, general malaise. Some patients may have more atypical types of symptoms, such as a sore throat, dry cough, fatigue, or nausea and vomiting. So those can happen as well. So for the elderly, we want to be really concerned if they have new onset of confusion or lethargy, which can indicate decreased oxygenation. Fever and dyspnea should also raise the index of suspicion for pneumonia for these folks as well. So complications, pleurisy and pleural effusion are two of the most common complications. Atelectasis or collapse of the alveoli can occur with trapped secretions, and then spread of the infection to other parts of the body, which can cause septicemia, meningitis, septic arthritis, or peri or endocarditis as well. So diagnosis, they'll do chest x-rays to look for infiltrates, sputum cultures again to identify what type of organism is the offender, and then blood cultures to ensure that the infection has not spread throughout the system. Therapeutic interventions, antibiotics can be given orally, or if they're really sick, they may give them to them IV. Antiviral medications, if it's a viral problem, something like Zovirax. They can also give bronchial dilators or expectorants, which can help with comfort and symptom relief. Supplemental oxygen, again, if they're hypoxic. And then fluids, which, again, will help to mobilize secretions. So tuberculosis, this is an acid-fast bacillus, which implant to the bronchioles or the alveoli. A tubercle is formed from the immune system response, which surrounds the infected area with neutrophils and macrophages, creating a lesion which seals off the bacteria, and this causes the bacteria to die, or it can just become dormant, which again can be reactivated anytime the immune system is impaired. So really the immune system kind of keeps this in check. Only about 5 to 10% of folks become ill. And then if they become immune compromised in the future, or there's any type of immune compromise that happens, then they can those bacteria can become active again. So people that are at risk, those that live in crowded conditions, new immigrants, those with HIV, really anyone with an impaired immune system is at risk. Signs and symptoms, active TB is characterized with chronic productive cough. They can have blood-tinged sputum, night sweats, anorexia and weight loss, a low-grade fever, and then dyspnea and chest pain, which are actually late signs. So diagnostic tests, they'll do that PPD test iteration after 48 to 72 hours would be considered positive. They can do chest x-rays to screen those with positive TB tests as a screening tool, just to see if there's any lesions there in the lung. They can do sputum cultures, again looking for that acid-fast bacillus. And then they can do the quantiferon TB Gold, which is a blood test that detects the cell-mediated immune response to the TB bacteria that's in the blood. So therapeutic interventions, there's a list of antibiotics that are used to treat TB in your book. It's on page 31, or it's on page 644, box 31-3. But there's a combination of drugs that are taken anywhere between 6 and 24 months. So INH, rifampin, or rifampin, streptomycin, and ethambutol. Occasionally they'll do surgical removal of the infected areas as well. And then these folks need to be on isolation until their sputum no longer contains the TB bacteria. They also need to be encouraged to have rest and good nutrition, again boosting that immune system so that they don't get sick. So you can imagine that the trouble here is that these medications have to be taken 6 to 9 months or even up to 2 years, so kind of difficult in getting compliance with some of these medication regimens sometimes. So prevention of the TB, prevention of spreading TB, having a clean, well-ventilated living areas, definitely isolation of patients who have active TB, high-efficiency filtration masks, so those N95s or the yellow duckbill respirators need to be used. Certainly gowns, gloves, and goggles if contact with sputum is at all likely. So nursing diagnosis for lower respiratory disorders, impaired gas exchange related to decreased ventilation or perfusion, ineffective airway clearance related to excessive secretions, ineffective breathing patterns related to anxiety or pain, and activity intolerance, which is related to the imbalance between oxygen supply and demand. We'll talk a little bit about restrict orders now. These are problems that limit the ability to expand the lungs and inhale air. So these are caused by reduced compliance or elasticity of the lungs or the chest wall. So pleurisy or pleuritis is an inflammation of the visceral or parietal pleurae that surround the lungs, and this inflammation causes friction between the pleural membranes, and as the person breathes in, the pleurae catch on each other, causing this really sharp pain on inspiration. It's related to other underlying respiratory disorders like we talked about, pneumonia. It also can be secondary to tuberculosis, cancer, or pulmonary embolisms as well. It also can be related to some non-respiratory disorders like pancreatitis or certain autoimmune disorders that can also result in pleurisy. So symptoms: sharp pain on inspiration. They'll have pain with coughing or sneezing as well. Shallow breathing and rapid, because deep breaths cause this really sharp pain. Fever, elevated white blood cell count, and chills if the cause is infectious. They also can have a pleural friction rub from those membranes catching on one another. So diagnostic tests, chest x-ray, CBC, they can also do these forced vital capacity testing, which is the total amount of air exhaled during the forced expiratory volume test. So these values would be lower in persons that have like asthma or COPD. And then they also want to do tests to determine if there's any underlying cause or what is the underlying cause of the problem. So therapeutic interventions, NSAIDs and opioids are given for pain and to facilitate coughing and deep breathing to prevent complications. And then again, whatever the underlying cause is, they'll go in and treat that as well. It's pleural effusion. This is excess fluid between the visceral and parietal pleurae. The pleural fluid is not reabsorbed, or it can be an overproduction of the fluid as well, and it can cause the lung to collapse. The fluid can be watery or transudative from the capillaries, or it could be exudative fluid containing white blood cells and protein. Oh, and there's right there. Transudative effusions are usually caused by like heart failure or liver or kidney disease, where the exudative effusions are more from an infectious process like pneumonia or tuberculosis. And then they're also commonly seen with things like lung cancer. Signs and symptoms: dyspnea, pain, cough, tachypnea, diminished lung sounds or even absent lung sounds over the effusion, and then also pleural friction rub may be auscultated as well. For diagnostic testing, chest x-rays to determine the presence of the effusion. They'll do a thoracentesis to drain the fluid and to collect samples to send to the labs for culture and sensitivity, and also for cytology. And then they'll also do tests to determine if there's underlying cause or what is the underlying cause. Therapeutic interventions, so figuring out what the underlying cause is and then treating that. Analgesics for pain. Thoracentesis or remove excessive fluids, and also to relieve that shortness of breath. Bed rest is also recommended to aid with healing as well. Pulmonary fibrosis or interstitial lung disease is a group of disorders that cause injury, scarring, and then fibrosis of the lung tissue, which leads to impaired gas exchange. So the etiology can be hereditary. It also can be caused by smoking, viruses, environmental or occupational exposures like wood and metal dust exposures, immune dysfunctions or autoimmune disorders like lupus or rheumatoid arthritis. Called idiopathic because fairly often there's no specific cause can really be found to the problem. Signs and symptoms: progressive dyspnea or shortness of breath, inspiratory crackles, chronic fatigue is pretty common, and then of course clubbing of the fingers from this chronic hypoxia, and then some will actually experience more like flu-like symptoms. So diagnosis: chest x-ray, this will show lung infiltrates, CT scans, they can do bronchoscopies or lung biopsies to rule out other causes. An ANA titer, which is a blood test to see if an autoimmune process is involved. On ABGs, their PaO2 will be low. They can also do spirometry to verify that the problem is restrictive. For therapeutic interventions, they can give glucocorticoids, which will help to decrease the inflammation, immune suppressants to help decrease the immune response, certainly smoking cessation, and also instructing the folks to avoid any secondhand smoke exposure as well. They can do supplemental oxygen if the person is hypoxic. They want them to get flu and pneumonia vaccines to prevent illness, which can exacerbate the problem. Pulmonary rehabilitation to maintain optimal activity tolerances, and then a lung transplant may be considered if the patient is younger. So atelectasis is a collapse of the alveoli. It could be from decreased aeration, and the alveoli become plugged with mucus, which prevents inflation. That hypoventilation is most common in post-surgical patients who do not cough or deep breathe effectively. So really important to talk to them about coughing, deep breathing, being mobile as soon as possible, and then position changes if they're unable to get up and about. So in symptoms: fine crackles, diminished breath sounds, and then dyspnea. For therapeutic interventions, the focus of nursing care is really on prevention, so patients should be taught the importance of coughing and deep breathing, either in sense of spirometer, turning or changing positions frequently as mentioned, and then ambulating as soon as they possibly are able. Nursing diagnosis for restrictive disorders would be impaired gas exchange, ineffective breathing pattern related to acute pain, or acute pain related to any one of those disease processes. So obstructive, this could be airway obstruction from airways that are narrowed or blocked by inflammation and mucus, making it difficult to exhale because it requires more effort for the weakened alveoli to push air out through the obstructed airways, and then it's really difficult to exhale. So COPD, a combination of disorders, again, chronic bronchitis, emphysema, and then asthma. And we talked about that asthma is not always considered part of the COPD unless it becomes very chronic. But these are all disorders that cause that chronic airflow limitation. All right, so pathophysiology. Chronic bronchitis really is in chronic inflammation, usually from inhaled irritants. It causes this impairment or impaired ciliary function and ineffective airway clearances. There's also this hypertrophied mucus glands or bronchi, which produce excessive thick tenacious mucus, which obstructs the airway and traps air, again causing that ineffective airway clearance. It's diagnosed after symptoms occur 3 months out of the year, 2 consecutive years. So it's just not jump to that conclusion right away, but when the person is having steady symptoms 3 months out of the year for 2 years, then they'll be diagnosed with COPD or chronic bronchitis. So emphysema is destruction of the alveolar walls, causing this loss of elastic recoil and damage to the pulmonary capillaries. Air trapping results from this loss of elastic recoil, so passive exhalation is impaired. Gas exchange is impaired because the destroyed alveoli and damaged capillaries reduce the surface area for gas exchange to happen. So there's different types of emphysema. So here in picture A, which is the top picture here on the right, you see normal lung, and then B is central lobular emphysema, which causes distended respiratory bronchioles, and then the bottom picture in C, you see panlobar emphysema and the damage to the respiratory, which has damage to the respiratory bronchioles and the alveoli. So air trapping, here the top picture in the diagram shows air trapping from excessive mucus, and the bottom picture shows air trapping from that decreased elastic recoil and narrowed airways. So the etiology, smoking is actually the single most important risk factor, but as discussed before, it can be caused by other things such as secondhand smoke exposure, pollutants. There certainly can be a familial predisposition, which is this alpha antitrypsin, which causes this predisposition to emphysema. Just of important to note, children of smoking parents are at a higher risk because of that secondhand smoke exposure as well. So folks, even though they're not smoking, if they are over time exposed to secondhand smoke, they also can develop COPD well. So this is just to derive the effects of smoking related to COPD over time. So prevention is important because there's no cure. According to the Global Initiative for COPD guidelines, smoking cessation is the single most effective and cost-effective intervention to reduce the risk of developing COPD, but also for slowing its progress. So if somebody's already been diagnosed with COPD, quitting smoking also will slow the progress of the disease. Signs and symptoms, cough, sputum production, dyspnea on exertion, prolonged expiration because of these or air passages, and that reduced elastic recoil. Barrel chest from air trapping, and then activity intolerances that are related to shortness of breath. So chronic bronchitis, signs and symptoms, wheezing, crackles, chronic productive dyspnea, thick tenacious types of sputum, increased susceptibility to infections, and mucus plugs. Emphysema signs and symptoms, use of accessory muscles, diminished lung sounds, certainly dyspnea, progressive activity intolerance, and shortness of breath. Late stages, they'll have weight loss and can be malnourished, secondary to the severe dyspnea, which makes it difficult to eat, and the expenditure of calories is increased from that, or expenditure of calories is higher because of that increased work of breathing. Complications of COPD, cor pulmonale, which is right-sided heart failure because the heart has to work harder to pump blood through the decreased lung tissue. Weight loss, as already discussed. Pneumothorax from the development of these bullae or blebs, which are these large air spaces that can rupture and then cause subsequently the lung to collapse. And then respiratory failure or infection, which can result in death for the patient. Diagnostic tests, chest x-rays, CT scans, they can do ABGs, CBCs, spirometry, and also sputum analysis. Therapeutic interventions, again, stop smoking, that's the number one. Folks can also be placed on oxygen, supportive care, also pulmonary rehab, surgery to remove really damaged types of tissue, endobronchial valve. This is a one-way valve that's placed in a diseased lung that allows the healthy lung tissue more space to expand. Mechanical ventilation, so doesn't cure the disease. It's really very, very difficult to wean off. So CPAP and BiPAP would be better choices or better alternatives if the patient's not too compromised. Certainly, because it is not a curable disease, end-of-life planning should be discussed ahead of time. Medications, bronchodilators, corticosteroids, and expectorants. They certainly shouldn't have any antitussives because we want these folks to be able to cough up secretions. And then they can use nebulizer treatments or multi-dose inhalers as well. Pulmonary Rehabilitation. These programs allow the patients to exercise in a controlled environment. It also gives them this psychosocial type of support from being around others with the same types of problems, and these programs help to increase exercise and tolerance and help maintain a sense of well-being. So asthma is characterized by inflammation or edema to the bronchial mucosa and spasms of the bronchial smooth muscles. This causes narrowing of the airways and air trapping. Symptoms are generally reversible. However, some people do develop permanent changes from chronic inflammation, and this is called airway remodeling, and it leads to this progressive loss of lung function. So etiology, it really tends to be inherited or hereditary. So this could be idiopathic or intrinsic, occurring in patients with no history of allergies, or it could be extrinsic, or there could be problems with airborne allergies, pollution, or exposure to smoke as well, which is just really, caused by any exposure to an allergen or other triggers. So that can happen as well. Some of the triggers are smoking, allergens, infections, sinusitis, stress, GERD from aspirated stomach acid, which can cause an exacerbation of symptoms. And then also, as discussed before, exercise can be a trigger for some folks. So signs and symptoms, dyspnea, wheezing as well. And it's important to note that the absence of audible wheezing may be a sign of improvement, but that it also can be a sign that the patient's not moving enough air to produce the sound. So really need to be aware that if a person is not wheezing and they're really feeling short of breath, that could be a very bad thing. Cough, sputum, use of accessory muscles, which is a late sign, it's immediate attention. And then these symptoms may be worse at night. Complications, status asthmaticus, which is a severe sustained asthma attack with worsening of hypoxemia. Respiratory alkalosis progresses to respiratory acidosis if it's untreated, and it can be life-threatening. Diagnostics, we want a really good history and physical exam like always. They also might do some spirometry or other pulmonary function types of tests. ABGs and then allergy skin tests to identify what triggers might be. Therapeutic interventions, so monitoring with peak flow meters. Again, these values differ based on age, height, and gender. Avoiding triggers, avoiding smoking, avoiding aspirin and NSAID drugs because these can cause symptoms in some people. Propranolol and metoprolol block beta receptors in the lungs, preventing promotion of bronchial dilation from the sympathetic nervous system. So these drugs should be avoided if they make symptoms worse as well. So Table 31.5 on pages 655 through 656 lists a summary of the medications that are used to treat lower respiratory disorders with examples of each of these drugs, their routes of administration, along with side effects and then nursing implications as well. So bronchial dilators, you'll see things like albuterol, Accolade Singulaire, and then theophylline is still used, but again, it's pretty rarely used anymore. Corticosteroids, they can be inhaled IV or PO. They can also use mast cell inhibitors, antihistamines, and then also oxygen as needed. Remember, for asthma, there is stepwise therapy with a goal to maintain control of the symptoms with the least amount of medications, thereby minimizing the risk for adverse effects. So the idea is to both reduce the impairment and also reduce the risk of recurrent exacerbations or loss of lung function from lung remodeling, and then to provide optimal control with minimal or no adverse effects. So cystic fibrosis, this disease is a genetic disorder where both parents are carriers and pass the disorder on to their offspring. It's an endocrine gland disorder that affects the lungs, GI tract, and sweat glands. In the lungs, abnormal sodium and chloride transport across the cell membranes causes thick, tenacious secretions. These secretions are difficult to remove, which cause obstruction of the airways, which results then in air trapping and then frequent respiratory infections. In the GI system, these abnormalities with the sodium and chloride transport cause the pancreas ducts to be blocked, so digestive enzymes are retained, which causes destruction to the exocrine pancreas, but also malabsorption of nutrients from the lack of the digestive enzymes. Patients also experience excessive flatus and then frequent foul-smelling fatty stools. Because the sodium and chloride are not reabsorbed as they pass through the sweat glands, patients with cystic fibrosis also secrete sweat that's really high in electrolytes, or in these electrolytes anyways. So signs and symptoms: thick, tenacious sputum, frequent respiratory infections, finger clubbing from the chronic hypoxia, malabsorption and fatty, foul-smelling stools from the GI pancreas issues. And then a lot of times these people will actually end up dying from antibiotic-resistant types of infection. So folks that are at risk, they have this campaign called Kiss Your Baby campaign, and this was actually to report any salty tastes, because again, that sodium and chloride would be high in children, so you would taste that sweat or the salt in their sweat. They can also do sweat chloride tests, which is a chemical that's applied to a small area on the arm or the leg, and then an electrical current is applied, and this causes sweating, and then that sweat is collected and sent to the lab to measure the amount of chloride that's in it. And then also there should be some genetic testing and counseling for parents as well. So therapeutic interventions, the goal of treatment is aimed at controlling infection and relieving symptoms. So hydration to promote removal of secretions. So they can have inhaled mucolytic medications, bronchial dilators or corticosteroids, expectorants, chest physiotherapy, and they can have that up to 4 times daily. Antibiotics, and then Pulmonase is an inhaled medication that breaks up and loosens that really has been shown to reduce lung infections and improve lung function as well with people that have cystic fibrosis. Therapeutic interventions, so prevent infections, so flu vaccines yearly, and also prophylactic antibiotic types of treatments. And then we talked about this pancreatic enzyme replacement, pancreas or Viocase, to reduce the symptoms related to malabsorption. Ibuprofen has also been shown to maybe slow lung deterioration because of the anti-inflammatory properties. And then ultimately, these folks may need a lung transplant. So nursing diagnosis for COPD: impaired gas exchange, ineffective airway clearance, ineffective breathing pattern, activity intolerance. So these would be the priority nursing diagnosis for most chronic respiratory patients. Imbalanced nutrition, less than body requirements related to poor appetite or increased caloric expenditure, again secondary to that increased work of breathing. And then anxiety related to that acute dyspnea. So patient education assists the patient to stop smoking, so referrals to smoking cessation programs. Pulmonary rehabilitation, this is an excellent resource for patients to have. Breathing exercises, and also anxiety control, and then energy conservation things as well. Pulmonary embolism, so this is a blood clot in the pulmonary arteries, be from fat or amniotic fluid as well, and the problem is there's this ventilation and perfusion mismatch, so the lung is well ventilated with air, but no blood flow or perfusion, causing seriously impaired gas exchange. Lung infarction happens when the lung is damaged from that lack of oxygen. So DVTs are the most common etiology. Fat emboli, again from compound fractures, amniotic fluid embolies during labor and delivery, and also can be from an air embolus from entry of air into the bloodstream. Prevention, regular ambulation, prompt treatment for DVTs in high-risk patients, Lovenox, heparin, SCDs prophylactically as well. So signs and symptoms include the sudden onset of dyspnea for no apparent reason, tachycardia, tachypnea, cough, crackles or a friction rub as well, hemoptysis, pleuritic chest pain. Diagnosis, spiral CT scan, lung scans, angiograms, D-dimers, again, ventilation perfusion or VQ types of scans, which are those ones done in nuclear medicine. They can do chest x-rays, ABGs, and also ECGs as well. Therapeutic interventions, thrombolytics to dissolve the clot, heparin and warfarin to prevent new clots from happening. Oxygen, even if SATs are normal, as this may help to dilate the pulmonary vessels. Embolectomy to remove the clot as well. It's pretty rare, but it can happen. Jugular or femoral filter for recurrent PEs, so those green-filled types of filters that can be inserted to catch a clot before it reaches the heart or lungs. Nursing diagnosis, empty gas exchange, and then risk for injury related to anticoagulant use as well. Pulmonary arterial hypertension, this is elevated pressures in the pulmonary arteries, and then right ventricle failure because the right ventricle has to work really hard to push blood through the pulmonary arteries. The etiology, so primary or unknown, has hereditary tendencies, and then secondary is from coronary artery disease or valve disease, liver disease, can be from systemic lupus, also from scleroderma. These are also associated with pulmonary arterial hypertension. So signs and symptoms, dyspnea is the most common. Weakness and syncope are also common. Fatigue, crackles, cyanosis, tachypnea, peripheral edema, and jugular vein distension if the heart failure is present, and angina from the right ventricular ischemia. Diagnostic tests, so ABGs, will show hypoxia and hypocapnia. Cardiac catheterization to determine pulmonary artery pressures can be done as well. ECGs may show right ventricular hypertrophy, and then additional tests to find the cause. So you might see things like chest x-rays, spirometry, lung scans, or pulmonary angiograms as well. Therapeutic intervention. There's no cure unless they do this heart and lung transplant. So that would need to happen. In secondary pulmonary arterial hypertension, we need to figure out what the cause is and then treat that underlying cause. But other things you'll see are low sodium diets or diuretics to reduce the volume, vasodilators to reduce pulmonary arterial pressures, oxygen, and then Coumadin or warfarin to prevent clotting. So nursing care, monitoring respiratory status, bed rest positioning, and then comfort measures. So positioning, we'll want Fowlers or high Fowlers that can help reduce shortness of breath. And then just measures, again, comfort measures to help with fatigue and anxiety as well. So pneumothorax, this is air in the intrapleural space. This can happen spontaneously from underlying lung disease like emphysema. It could also happen from trauma or broken ribs or any other penetrating chest type of wound. It can be complete or partial collapse of the lung. Spontaneous pneumos occur mostly in tall, thin people, but also in smokers as well. Pneumos can be open, allowing air to enter and escape through the opening in the pleural space. Enclosed, the air collects in the space and is unable to escape. So if too much air builds up in the closed space, then a tension builds in thoracic cavity, placing pressure on the heart and the great vessels, and this is called a tension pneumo. And it's very serious and it requires immediate intervention. So signs and symptoms of pneumothorax, shallow rapid respirations, asymmetrical chest expansion, dyspnea, chest pain, and then absence of breath sounds over the affected area. So the tension pressure, again, that can push the heart and the great vessels away from the affected side, causing this mediastinal shift. The compression of the heart and the great vessels impairs venous return and reduces cardiac output, which can lead to shock. You could see tracheal deviation, bradycardia, cyanosis. I guess I should mention that Pneumothorax as well, which is a blood in the pleural space, and this is usually caused by trauma, but can also be caused by cancer, pulmonary emboli, or anticoagulant therapy, and these also require immediate intervention as well. So diagnostic tests, good history and physical examination. They can do bedside ultrasounds as well. Chest x-rays or CT are done initially, and then they can be done serially also to monitor resolution following treatment. ABGs, SpO2s are monitored throughout treatment. So therapeutic interventions, they can put in a Heimlich valve. It's not too big. They're going to monitor ABGs and also respiratory status, of course, continuously. Chest tube to water seal. They can also do the pleurodesis or sclerosis for recurrent collapse, and this is where antibiotics or sterile talc is injected into the pleural space, which irritates the pleural membrane, which makes them stick together. This is a very painful procedure, so if the patient is going to have this type of procedure, you need to make sure that they're pre-medicated very well for pain prior to the procedure. Care, monitoring respiratory status, level of consciousness, skin color, temperature and moisture, vital signs, O2 stats or SATs, work of breathing. Are they having any chest pain, anxiety, or restlessness? Monitoring the chest drainage system. FOCA is a mnemonic that's used to evaluate chest tubes, so fluctuation in the water seal chamber. Output, we want to look at the type and the amount, the color of the drainage, and then are there any air leaks. And then we want to report any changes promptly. So rib fractures, etiology can be trauma or cough, especially with people that have osteoporosis or cancer. Also can be caused by CPR. They can be very painful and prevent the patient from taking deep breaths or coughing effectively, which can cause atelectasis and pneumonia. And as mentioned, broken ribs can also cause pneumothorax by damaging the lungs. In addition, they can damage any of the underlying organs. So really for care, we want to control pain, encourage coughing and deep breathing, and then promote adequate ventilation. Flail chest, this is multiple rib fractures, usually defined as 3 or more adjacent ribs broken in at least 2 places. The rib cage is not able to maintain this bellows action, and the affected part of the chest collapses with this negative pressure of inspiration and then bulges with expiration, which is called paradoxical respirations. So for care, monitoring ABGs, they may require mechanical ventilation, oxygen, pain medications for sure, and then monitoring again for signs and symptoms of a pneumothorax. Nursing diagnosis for chest trauma, impaired gas exchange related to ineffective ventilations, ineffective breathing pattern related to this paradoxical respirations, and then acute pain related to trauma. Acute respiratory failure. So this is hypoventilation and then the inability to maintain ABGs. So hypoxemia may be caused by this hypoventilation or poor oxygenation or both. In either case, acute respiratory failure is diagnosed when the patient's unable to maintain adequate ABG values. So the etiology, COPD, aspirations, certainly neurological deficits that affect muscles of breathing, such as stroke, spinal cord injuries, or myasthenia gravis. Any acute respiratory infection, inhalation of toxic substances or drug overdoses as well. Signs and symptoms, worsening ABGs, increased restlessness or confusion, lethargy. They can become cyanotic and dyspneic. Respirations become deep and then rapid as they try to blow off the CO2, and then coma and death will happen. Diagnose PaO2s that are less than 60 or PCO2s that are greater than 50. You want to do tests to determine the cause, so you may see sputum cultures, chest x-rays, and other tests as well. Again, to determine that underlying cause to guide the treatment. Therapeutic interventions, antibiotics, bronchodilators, correcting the underlying cause. Intubation and ventilation. They can also use BiPAP or CPAP. Certainly before intubating anybody, we want to check advanced directives to make sure that that's what they would like us to do. Syndrome, ARDS, ARDS. Here, the alveolar capillary membrane is damaged and the chemical mediators are released, causing the membranes to become leaky, causing this pulmonary edema. And then there's alveolar collapse, and then fibrotic changes that take place, causing the lung to become stiff and less compliant. And then the lungs may hemorrhage as the condition worsens as well. ARDS occurs, again, there's this acute lung injury, such as sepsis or shock or aspiration. It's not usually in patients that have these chronic respiratory diseases, but usually affects patients without a previous history of lung disease. Signs and symptoms: dyspnea, elevated respiratory rates, fine crackles, respiratory acidosis, restlessness, and confusion. It's a very high death rate. About 45 to 50% of patients that get it will die. But the good news is that those who do survive tend to recover completely from the problem. So diagnostic tests, ABGs. Chest x-ray will appear whited out because of the excessive fluid in the lungs. ECG to rule out cardiac-related causes, and then, of course, diagnostic tests to look at if there are any underlying causes, or what is the underlying cause. Therapeutic interventions, oxygen, intubation, and they'll also have mechanical ventilation, and they'll have PEEP to keep their airways open. Treating the underlying cause, so you may see diuretics to reduce like pulmonary edema, or antibiotics if an infection is suspected. Supportive care, like nutritional support as well. Positioning or putting the patient with the good lung or less involved lung down to increase blood flow. Prone position has also been shown to help increase oxygenation with patients that have ARDS as well. Nursing diagnosis for respiratory failure, impaired gas exchange, ineffective airway clearance, ineffective breathing pattern, activity intolerance, anxiety, disturbed thought processes, or self-care deficits as well. Lung cancer, there are 4 major types of lung cancer, and they're classified by the type of cell that are involved, and include small cell cancer, large cell carcinoma, adenocarcinoma, which is closely linked with smoking, and then squamous cell carcinoma, which tends to have a better outcome or prognosis than the other types of lung cancer. So etiology, smoking, which causes about 90% of all lung cancers. Smokers are 13 times more likely to develop cancer as non-smokers, or lung cancer as of non-smokers. Environmental tobacco smoke, or secondary exposure, or secondhand smoke is also a cause. But we've also talked about other carcinogens that can be players, such as asbestos, arsenic, pollution, and then also diesel exhaust as well. Signs and symptoms, really none until a little bit later. It's commonly not diagnosed until it is metastasized, causing problems elsewhere. Also may have productive cough, recurrent infections or dyspnea, hemoptysis, anorexia and weight loss, pain or wheezing or stridor caused by a upper respiratory type of obstruction. Some of the complications, so pleural effusion, about 50% develop pleural effusions. Superior vena cava syndrome, which is where blood flow is interrupted, which causes this distension in the jugular veins, leading to this swelling in the chest and the face. There can also be ectopic hormone secretions. So with lung cancer, remember when we were talking about endocrine problems, that they can cause endocrine dysfunction. So they can secrete ADH, causing SIADH, or ACTH, causing Cushing's syndrome, or PTH, also causing that hypercalcemia. So that can happen. And then also atelectasis and pneumonia. And then metastasis, of course, can happen. Common sites are the brain, bones, liver, adrenal gland, lymph nodes, and then the opposite lung as well. For diagnostic tests, certainly a really good history and physical, looking for risk factors. Chest x-ray to identify masses. CT scan or PET scan to provide more specific evaluation of the tumor. Sputum analysis, looking for abnormal cells or biopsy. And then additional tests to find metastasis like brain or bone scans or things like that. Therapeutic interventions, they still use that same staging scale, so the TNM system. Chemotherapy and radiation are usually palliative. They can do surgery with lobectomies or removal of the entire lung. As discussed before, they also can use those monoclonal antibodies as well, and anti-angiogenesis agents and growth factor inhibitors as well. Nursing diagnoses for lung cancer include impaired gas exchange, ineffective airway clearance, imbalanced nutrition, pain related to procedures, constipation, anticipatory grieving, and then activity intolerances related to discomfort or shortness of breath. Thoracic surgeries, this can be a pneumectomy or removal of the entire lung. Lobectomies, which are removal of one of the lobes of the lung. Resection, which can be a removal of the smaller amount of lung tissue, but less than an entire lobe. VATS is a video-assisted thoracoscopic surgery, or which can be used as well. This is actually, like all of those video-assisted types of procedures, is less invasive because it can be done through 2 or 3 small incisions as opposed to opening up the entire chest. And then also they can be transplant types of surgeries that happen as well. So preoperatively, you want to gather really good baseline data and then let the patient and family know what to expect postoperatively. So really monitor their status and then talk to them about routine, normal pre-op types of stuff, what to expect when they come out. Visit the unit where they're going to come out so that they see where they're going and the setup and the layout. And then really important to include the family as well so that they know what to expect. Postoperatively, they should be in an intensive care setting. They'll get really close monitoring of vital signs, SpO2 and ABGs, and then hemodynamic monitoring as well, monitoring of lung samples. They might and also have chest tubes. So we're going to assess for complications such as pneumothorax, monitor the chest tube, and then monitor for pain and infection as well. Nursing diagnosis, ineffective airway clearance related to ventilator use, inability to cough, sedation, impaired gas exchange related to removal of lung tissue or opioid use, acute pain related to the procedure, impaired physical mobility related to discomfort, and then risk of infection related to all of the multiple lines that they may have. So the Foley, IVs, etc. And so risk for infections. Remember that you can always make an appointment with or text me form.